Hello everyone, it's Dr. Atkinson. Today we're diving into obstruction and trauma of the upper respiratory airway, specifically obstructive sleep apnea, often called OSA. Let's start with a definition. OSA is a disorder where people have recurrent episodes of upper airway obstruction during sleep. This leads to reduced ventilation and repeated apneic episodes, meaning complete cessation of breathing. These pauses usually last 10 seconds or longer. Now here's the big picture. OSA is common. In fact, it's estimated that about 26% of adults between 30 and 70 have it. In the United States, 4 to 9% of women and 9 to 24% of men are affected. What's even more concerning, up to 90% remain undiagnosed. One of the major reasons behind these rising numbers is the obesity epidemic. Why does this matter? Because OSA interferes with rest, and that impacts memory, learning, decision-making. Basically, the brain doesn't get the reset it needs. Risk factors. Let's talk about who's at risk. The biggest risk factor is obesity. A large neck circumference and increased fat around the airway can narrow and compress it. Other factors include male gender, postmenopausal status in women, and advanced age. Structural issues like enlarged tonsils, certain jaw positions, or craniofacial variations can also make the airway more collapsible. And here's a clinical pearl. Because OSA is so often linked with hypertension, every adult with high blood pressure should be screened for OSA. So what's happening in the body? Think of the pharynx as a collapsible tube. During sleep, muscle tone in the upper airway decreases. With a narrowed airway, even small amounts of negative pressure during inspiration can cause the airway to collapse. This leads to repeated apneic events. The result? Hypoxia, low oxygen, and hypercapnia, high carbon dioxide. These trigger a sympathetic nervous system response, which is why OSA patients often develop hypertension. But it doesn't stop there. OSA is also linked to an increased risk of myocardial infarction and stroke. Clinical manifestations. How do patients present? The classic features are remembered as the 3 S's: snoring, sleepiness, significant other reports of apnea episodes. Patients may snore loudly, stop breathing for at least 10 seconds, then suddenly wake up with a loud snort as oxygen levels drop. They may have anywhere from a few episodes per hour to several hundred each night. Over time, symptoms progress with weight gain and aging. Other common signs and symptoms include excessive daytime sleepiness, frequent nighttime awakenings, insomnia, morning headaches, irritability, personality changes, or intellectual decline, systemic hypertension and arrhythmias, pulmonary hypertension, cor pulmonale, or even polycythemia in chronic cases. Some patients also report impotence or even bedwetting, enuresis. One more key point, patients often don't know they stop breathing. Instead, they'll complain of insomnia, fatigue, and daytime hypersomnolence, meaning they fall asleep while eating, talking, or even driving. The gold standard for diagnosis is a polysomnographic sleep study. This overnight study records EEG for brain activity, eye movements, chin and leg muscle activity, cardiac rhythms, airflow at the nose and mouth, breathing effort, and oxygen saturation. Findings consistent with OSA include apneic episodes lasting 10 seconds or longer, occurring despite respiratory effort and being most common during REM sleep. Often, arousal from sleep occurs at the end of each apneic event. Medical management. Most people seek help because their partner notices loud snoring or because they're excessively sleepy during the day. First-line interventions include weight loss, avoidance of alcohol, positional therapy, avoiding sleeping on the back, oral appliances like mandibular advancement devices, or MADs, which move the jaw slightly forward to keep the airway open. For more severe cases, we use positive airway pressure therapies, CPAP, continuous positive airway pressure, which prevents airway collapse, BiPAP, bilevel positive airway pressure, which helps make breathing easier with 2 pressure levels. Both may be used with supplemental oxygen if hypoxemia is severe. When other therapies fail, surgery may be considered. Options include tonsillectomy for large tonsils, uvulopalato-pharyngoplasty, which removes part of the uvula and soft palate, nasal septoplasty for significant septal deformities, maxillomandibular advancement surgery to enlarge the airway, and in severe, life-threatening cases, a tracheostomy, though this has major drawbacks like speech difficulties and infection risk. Pharmacologic therapy medications don't cure OSA, but can help with symptoms. Modafinil or armodafinil may be prescribed for persistent daytime sleepiness despite CPAP. Protriptyline at bedtime can increase respiratory drive and improve airway tone. Medroxyprogesterone acetate and acetazolamide may be tried in certain cases, though benefits are limited. Low-flow nighttime oxygen can help relieve hypoxemia, but does little to reduce the number of apneic episodes. Nursing management. Finally, let's look at nursing care. The nurse's role is primarily education and support. Patients may not understand the seriousness of OSA, so we explain the disorder, connect symptoms like daytime fatigue to the underlying condition, and reinforce the importance of treatment. We also provide instruction on safe and correct use of CPAP, BiPAP, and oral appliances, the risks of untreated OSA, and the benefits of compliance with therapy. That wraps up our overview of obstructive sleep apnea. Remember, it's more than just snoring. It's a condition with serious cardiovascular and neurologic consequences. Early recognition and proper management save lives.